Good evening, good afternoon, good morning. A warm welcome to everybody. This is episode 21 of Virtual Bariatric University. And today we are presenting before you laparoscopic gastric bypass, a bariatric and a metabolic operation. So gastric bypass, as all of you know, is one of the oldest bariatric procedures performed across the world. With the resurgence of sleeve gastrectomy, gastric bypass numbers have decreased all across the world, but still there is a place for this procedure for select group of patients, and we will discuss about it today. We have a great group of faculty today, very learned, very skillful, with huge amount of experience. I would start from welcoming Dr. Shanu Kothari from United States of America. Shanu is currently the Vice Chair of Medical Staff Affairs in the Department of Surgery at Prisma Healthcare in Greensville. He is also the Associate Professor of Surgery at the University of South Carolina Hospital. Prior to this, 18 years he was at Gunderson Clinic in La Crosse, and now he is serving as the Associate Professor in South Carolina. Dr. Kothari has authored over 130 publications in peer-reviewed journals, 18 book chapters, and has served as a senior editor of 2011 and 2021 surgical clinics of North America, dedicated to bariatric and metabolic surgery. He is currently the president-elect of the American Society for Metabolic and Bariatric Surgery. Welcome, Professor Kothari. Next, we have Dr. Jan Greve from Netherlands. Jan is in the Department of Surgery at the Zwitserland Medical Center, and since 2008, he has been serving that center. He is presently the chair of GI surgery and the chair of bariatric surgery program. He is also the medical director of Dutch Obesity Clinic. He is a professor of metabolic and bariatric surgery at Maastricht University Medical Center in Netherlands and co-founder and the past president of Benelux Association for Bariatric Surgeons. He is a member of editorial board of Obesity Surgery from January 1998. Associate editor of Obesity Surgery since March 2000. He served as the president of IFSO 2005-6. He was the organizer of the third World Congress of IFSO in Belgium and the organizer and president of the 10th World Congress of IFSO in 2005 in Netherlands. He is the president-elect Board of Trustees of IFSO. Welcome, Professor Jan Greve, to Virtual Bariatric University. We have Professor Matthew Kroh from Dubai. Matthew is now Associate Professor in Cleveland Clinic. He was previously at Ohio and Cleveland in USA, but now most of his practice is in Abu Dhabi in the Cleveland Clinic. He's an Associate Editor for Bariatric Surgical Practice and Patient Care on the editorial board of SOD. He's a Professor of Surgery and Adjunct Clinical at Khalifa University of Science and Technology, College of Medicine and Health Sciences. He served as the program director for the Advanced Laparoscopic Surgery and Flexible Endoscopy Fellowship, and also has been the director of surgery in Cleveland Clinic, Lerner College of Medicine, and the surgical director of both Advanced Endoscopy Center and Esophageal Center. He has held the position of director for the Center of Advanced Skill Training in Cleveland Clinic Simulation Center. Very active researcher, has authored more than 100 peer-reviewed articles, 25 book chapters, many textbooks. Welcome, Professor Kroh, to Virtual Bariatric University. We have Dr. Ramen Goel from India, Mumbai. Dr. Ramen Goel is a director of Bariatric Metabolic Surgery Program at Wockhardt Hospital in Mumbai. He is the president of IIGS, the program director of IMAST in Mumbai. Also the chairman of Scientific Committee WCE 2024, associate editor of JMAS, editorial board member of Indian Journal of Surgery, the first Indian Surgeon of Excellence in Bariatric and Metabolic Surgery, recognized by Surgical Review Corporation. Also has a Center of Excellence in Bariatric and Metabolic Surgery, endorsed by SRC USA, and as a Center of Excellence in Bariatric and Metabolic Surgery, endorsed by the Obesity Surgical Society of India. Welcome, Professor Ramen Goel. We look forward to interact with you. To add to this evening, we have Dr. Vinod Menon from United Kingdoms. Vinod is consultant bariatric upper GI and general surgeon at University Hospital Coventry, NHS Trust, UK. He is the honorary associate clinical professor at the University of Warwick. Vinod served as a clinical director for surgical services for 11 years, current president-elect for Council of British Obesity Surgery Society. He's been the honorary treasurer, honorary secretary for BOMS, director of the West Midlands Surgical Training Program, one of the best cadaveric training program and facility in United Kingdom. He's an examiner with the Royal College and the section editor of the Oxford Textbook of General Surgery for Bariatric Surgery. Welcome, Dr. Vinod Menon. It's an honor to have you at the Virtual Bariatric University. Furthermore, Dr. Frits Berends from Netherlands. Frits is a great friend, has a high volume center in Netherlands, and substantial part of his professional career has been dedicated to teaching surgeons learning about the minimally invasive technique of bariatric and metabolic surgery. He is a director of the Vitalis Obesity Center, which is very high volume, one of the highest volume probably in the world. Dr. Berends is a leading surgeon in Netherlands in the field of bariatric surgery. He was the principal investigator in many studies and publications on treatment of obesity. He was the board member of Dutch Society for Bariatric and Metabolic Surgery and the chairman of Dutch Guidelines Committee on Surgical Treatment for Obesity. Frits also is, in his most recent research, he has focused on the basic aspects of Roux gastric bypass design and how this particular surgery can be improved in terms of its techniques and results. Frits, you have huge amount of experience, and considering the volumes you do, I think the words of wisdom from your side would benefit all our viewers. Welcome to the Virtual Bariatric University. Professor Sarfaraz Baig from Kolkata in India is a director of digestive surgery clinic in Bellevue Clinic in Kolkata, specializes in bariatric, hernia, and GI surgery. His fellowship of IAGS, fellowship of advanced laparoscopic surgery, fellowship of bariatric and metabolic surgery, and was the main organizer for HSICon in 2019, and has been the organizing secretary for several national conferences, including OSCE. Welcome, Dr. Sarfaraz Baig. It's an honor to have you here on Virtual Bariatric University. So Sarfaraz is one of the highest volume surgeons doing bariatric surgery there in West Bengal, and words of wisdom from his side will be very beneficial to most of our viewers who want to start bariatric surgery. Myself and my mentor, my teacher, Professor Fobi, the clinical director of this center, both of us, we welcome you for the Virtual Bariatric University. These are COVID times, so we have to do this virtual. Otherwise, I know that most of those surgeons who are on the panel would have come to Indore to enjoy the hospitality here of our city, operate live, interact with a lot of young surgeons. But at this time, myself and Professor Fobi, we thought to do all these things virtually so that we keep in touch, spread and disseminate the knowledge despite COVID-19 pandemic. I would like to invite at this time Frits, Sarfaraz and Vinod for the first lecture session. And Professor Shanu Kothari is our first speaker. It's an honor, Professor Shanu. Please go ahead with your lecture. Thank you.
I'd like to thank Dr. Fobi for the opportunity to present in such a distinguished forum. My disclosures will have nothing to do with this talk. I do want to honor two of the fallen legends within our field. We lost many this year, but Dr. Mason, the father of bariatric surgery and of the loop gastric bypass, and Dr. Ward Griffin, who added the Roux component to it. Without their innovative thinking and contributions to the field, perhaps our society would not exist as we know it today. Many things have come and gone since the gastric bypass, some of which are listed here, all of which I have seen in my lifetime. But many procedures have come and gone as well, many variations of which are listed on this slide. But the gastric bypass has stood the test of time. Now, our understanding of how it works has fundamentally changed from purely a restrictive component and a malabsorptive one to one of our encompassing the idea of metabolic surgery, or Greek for change. Now we know that there are significant hormonal contributions to the powerful weight loss intervention that gastric bypass offers, including ghrelin, peptide YY, and the powerful incretin effect of GLP-1. I have the privilege of having the original brochure that Dr. Mason used as my senior partner, used to work for him. And you can see in 1975, a 3% mortality rate was quoted. We are now to 0.3 and even less than this. We have literally moved the decimal in terms of the care of the patients, in terms of mortality in such a short amount of time. We're closer to 0.2 and 0.1% mortality now, which parallels that of a gallbladder surgery. And so significant strides have been made. That being said, the bypass is the second most common procedure in the US, far behind the sleeve gastrectomy. Reasons for this are varied and plentiful, but go beyond the scope of this particular talk. We all should be familiar now with the article in 1995 Dr. Portes wrote showing the powerful anti-diabetic effect that gastric bypass had. We now have over a dozen prospective randomized trials showing superiority specifically around gastric bypass over maximal medical therapy. I followed this up then with a tribute editorial in the Annals of Surgery, not only highlighting the powerful effects that we still continue to have in a prospective randomized level of data, but the barriers that we have to still overcome to get this endorsed by our primary care colleagues as a mainstream treatment for diabetes. One of the criticisms is our lack of long-term data. And we all know the reasons for this are varied, why patients don't come back. This was my own institutional data, and I'm sure your follow-up curves are very similar in terms of patients showing up in the Bariatric clinic itself. We were able to mine the electronic health record and fill in the gaps with these blue bars. These are patients who came back to the system, either to primary care or to another subspecialist, where we could get the weights and we could see what was going on with their comorbid conditions over time. As you can see, we can get real-world data showing the durability of the weight loss, or in BMI units, if that is what you prefer as well. We showed significant and sustained improvement in a variety of comorbid conditions as listed here as well. So much so, the ASMBS has now looked at all of the longer-term data papers out there and put together a statement on this. And in red, you can see what can be estimated in terms of weight loss at long-term outcome around the 10 years time frame. We still need more studies looking at this, and one significant contribution to literature just came out last month, a landmark follow-up article by Dr. Rubino's group looking at a prospective randomized trial of maximal medical therapy for diabetics to biliopancreatic diversion and gastric bypass. Sort of the usual demographics, if you will, between the groups is listed here. More importantly, you can see the profound and significant difference between, as expected, the weight loss curves of conventional weight loss versus the two surgical interventions. On the top graph, though, you do see, other than a more powerful anti-glycemic operation, you do see a little bit of a bump up in some of those A1C levels over time, but then it does level out once again. Of note, this particular study did not look at early diabetics, less than 2 years duration, like many other studies. This was more real-world patients. These patients had to have more severe diabetes, longer duration, over 5 years. And so I think that still shows the powerful metabolic impact that gastric bypass has compared to maximal medical therapy. You can see here the gastric bypass had a 25% remission rate at 10 years in the intention to treat analysis. All surgical decisions must be balanced against longer-term side effects, one of which is iron deficiency anemia. I was shocked when I began to look at this in my own patient population and saw that 6.7% of patients required IV iron therapy, and half of them were iron deficient at some point in their post-operative period. And this IV iron treatment isn't just in the first year or two. It can happen longer-term follow-up is where they would still need for IV iron therapy. And it's not just one and done. Some will need several episodes of IV iron treatment over the course of their career after gastric bypass. We followed this up with an interesting article where we found 16 patients then who had developed pica in this iron deficient population, all of which were female, all of which were relieved of the pica cravings and symptoms with IV iron therapy. So it's just something to keep about in the back of your mind as you see your patients longer term in follow-up from this patient population. Another interesting longer term complication that can occur is nephrolithiasis, particularly oxalate stones that can occur after gastric bypass. Far higher incidence after gastric bypass than sleeve gastrectomy. The highest risk patients are those who had a history of oxalate stones, then went on to have a gastric bypass. Their odds ratio was 8.8. So much so I began to counsel patients about this during my pre-op determination for selection of procedure. Another thing that must be taken into consideration is the potential development of alcohol use disorder. The ASMBS has a statement on this, particularly more prone in the gastric bypass than sleeve population because of the rapid absorption that can take place as well. Something to take into consideration when counseling your patients. Bone mineral density also, the only added benefit to being overweight is that extra stress load results in stronger bones. Obviously, losing weight as well as the preferential site of duodenum from calcium absorption, which is bypassed, can put a patient at increased risk for bone mineral density demineralization. We saw this in a trial where we studied patients prospectively, and you can see just at 1 year the significant lowering of the density of the bones at 1 year after gastric bypass at key locations within the body. What this happens at 10 and 20 years perhaps still needs to be studied further. As one would expect, perhaps again, because of the altered anatomy and lack of the duodenal site for absorption of calcium, it's higher in the gastric bypass patient than sleeve on meta-analysis. One of the most feared surgical complications, of course, is internal hernia with subsequent obstruction and strangulation. We tried to look at this from a route of the rouleum to see if it impacted the bowel obstruction rates, leak rates, and things of that nature. And because there are theoretical advantages to retrocolic versus anticolic and vice versa. When we reviewed the literature, about 2/3 performed this in the anticolic, antigastric fashion. And perhaps, as one may surmise, that the bowel obstruction rate was higher when the route was retrocolic, retrogastric, again, because of the mesocolic stenosis that was probably occurring from too tight a closure or cicatrix formation around the rouleum at that level. We were unable in this analysis to look at the impact that leak rates had on this patient population because most did not report it. So another opportunity, perhaps through the MBS-AQIP analysis, that we could get that level of data based on route of rouleum. We're all faced with the dilemma on what to do in the post-gastric bypass patient with choledocholithiasis. Most of us prefer to transgastric ERCP, where we gain access through the excluded stomach. The ERCP sphincterotomy can then be performed and then close the subsequent defect in the excluded stomach. Superior mesenteric artery syndrome is a rare condition that results in a unique problem after gastric bypass, as the patient cannot vomit up following the duodenal occlusion, as noted here. As also noted here, the compression between the aortomesenteric angle. This is treated with a laparoscopic duodenojejunectomy, often because the other treatment, which is weight gain, is often not something the patients are interested in attempting to pursue following successful weight loss with gastric bypass. Another unique complication is the candy cane roux syndrome, where the blind tip can either remain technically too long to begin with or begins to elongate over time as the patients begin to use it as a so-called neo pouch. The treatment, of course, is resection and alleviation of some of these symptoms associated with it. Now, as we begin to close, we must also balance the gastric bypass against, in this case, the sleeve gastrectomy. And in general, most meta-analyses that have looked at this, and you can see from these forest plot curves, show everything favoring the gastric bypass in terms of weight loss, and as you would perhaps surmise, is comorbidity reduction as well. This is always balanced against an increased risk of complications in the bypass population compared to sleeve as well. As the more powerful the metabolic Bariatric operation is, in terms of weight loss and comorbidity reduction, we see a subsequent increase in complications and potential nutritional deficiencies as well. Currently, the bypass sits nicely between the sleeve and the duodenal switch in terms of this risk-reward model. Where the SADI will fit into this, I think, remains to be seen. So in conclusion, this is one of the conditions that I favor the gastric bypass in. These are conditions that I favor not going ahead with the gastric bypass and considering a different surgery. In this article, it showed 9 inventions that were so perfect they never required improvement. I think the article was wrong because it should be 10, and I think I would add the gastric bypass in there as well. And finally, any decision for gastric bypass must be carefully weighed against potential long-term side effects and subsequent surgical complications, as well as that decision must be carefully weighed against other bariatric surgical procedures. Thank you very much.
It was a great lecture as usual. I have a couple of questions for you. The first one being that by your own experience and data from your own center, what's your weight regain at 5 years after a non-banded gastric bypass? And why, if any circumstances, would you prefer to band your bypasses or you would not? That's my first question to you. And my second question, preferably to you, would be that if you have a cirrhotic patient who come to you in your practice with very severe diabetes and patient is on a very high dose of insulin, would you still go ahead and do a conventional gastric bypass or not? These are my 2 questions to you.
Yeah, great questions. First is the weight at 5 years. I'd have to go back and look at my graph because we had it, we had the 10-year data, but we also had it at the midterm point. I think it's very similar to, I think the curve is patients lose weight, they nadir, they gain a little bit, and we want them to stay there. The goal is to prevent further weight regain at that point. And I think it's a matter of what percentage of patients are able to keep a significant amount of weight off long-term. And that's an area of debate in terms of how we're going to define success in terms of, is it comorbidity reduction? Is it just pure weight loss? Or is it or quality of life or a combination of all of those? I personally have no experience with the band on the bypass. I know that you and others have done that and published on it and shown superior weight loss. I'd be curious if that is the restrictive component of that, or is that ring or band somehow stimulating some kind of a hormonal or neurohormonal effect to affect satiety or not, and I would defer to your expertise for that. Regarding cirrhosis, I counsel the patients that it could range from aborting the procedure once we get in, if we don't feel it is comfortable to proceed, but I have in select cases proceeded with the gastric bypass in that situation. My concern about the portal flow after sleeve gastrectomy and the known increased risk of portal mesenteric venous thrombosis in that population anyway scares me, and thinks that that may or may not be in the patient's best interest, a sleeve in that level of cirrhosis. So I try to proceed with bypass, but if for some reason I think based on varices that were not diagnosed pre-op, if they are there to the point where I don't think it's worth proceeding, I would abort at that point.
Yeah. Okay. We have done a couple of patients who are cirrhotics with severe diabetes and on insulin. The results were good because the limb lengths which we use at our center, the limb length is pretty less, so it's around 80 centimeters of a BP limb. It's not too much. Although in severe diabetes, we usually reverse that. But when they are cirrhotics and we keep our limb lengths, limited, we usually did not have such kind of problems which you said. And we're comfortable doing Roux gastric bypass and cirrhotics with diabetes. So I was just curious about your practice. Plus, I just wanted to understand, I was very curious, what do you do when your gastric bypass fails? I mean, what's the procedure of choice for revising your failed gastric bypasses? You have a lot of experience with them. So how do you manage them?
Yeah, no, I think it's a fair question, and I think we always go right to surgery, and we all see this at our national meetings when we see complex revisional surgery. But I do think we need to start with the multidisciplinary team approach. And so we go back to the basics of follow up with our nutrition, follow up with our psychologist, medical weight loss. Is there a role for pharmaceutical therapy? We tried to exhaust all of those before we would consider anything else. But I'll be honest with you, unlike a sleeve with weight regain, we don't have a lot of good options for regain after gastric bypass. If you've chosen that path, you're kind of in it to win it. And if you fail that, you're setting yourself up for some very complex revisions, as you know very well.
Yeah, I agree with you. Revising a gastric bypass is I think it's the most challenging surgery to revise. I have had opportunities a couple of times, and we usually would resect this pouch, band it, and distalize it. But as you correctly said, it's not an easy procedure technically. Plus, the results would vary depending upon what sort of common limb we have. Thank you, Shanu. I think at this point, Dr. Fobi would want me to stop. You have a huge amount of experience, and the questions can go on and on. But I think we should have the next speaker now. So let's start with the next session.
Ready to go?
The moderator for the next session. Can you unmute yourself?
Yeah.
I think it's up to me to introduce to you Jan-Willem Greve. That's the way we pronounce it in the Netherlands. He needs little introduction because all of you know him already from his extensive experience and presentations that he's done over the years. We heard the introduction earlier. He and me date back to the beginning of this century, around 2004, I think. Although his experience is far greater than mine, he was one of the pioneers in the Netherlands in the 90s already, embarking on laparoscopic VBGs and laparoscopic bands in that period. We published a few times together, especially on the endobarrier device. And for all those reasons, apart from being an excellent surgeon, he is now the only professor in the Netherlands in metabolic surgery, and obviously that's well deserved. He's going to enlighten us about the complications that you can stumble upon in doing gastric bypass surgery, especially in the peri-operative period. Jan-Willem.
Share the screen.
Well, thank you for the kind invitation. And while my presentation is going to start now, I'd like to thank Mohit, Bhandari and Fobi for the invitation to present. And then actually the invitation was to present on how I do the gastric bypass, and then of course of the peri and intraoperative complications. And that's quite a challenge because the time is limited. These are my disclosures, and this is my case mix. You see, I do mainly bended Roux-en-Y gastric bypass. And in the Netherlands, actually, the bypass is more popular than the sleeve, where it used to be the opposite. So the future may be different. I'm going to address the gastric bypass, how I do it. You need good exposure, so that's an overview as well. Some intraoperative complications and early complications. It was mentioned already, the Roux-en-Y gastric bypass has a long history, starting in the 70s of the past century. Initially horizontal, now vertical pouches, non-transected versus transected pouches. Bend or no bend has been going up and down, and our host Fobi has a lot of experience on that. Short limb, long biliary limb, etc. And I'll try to address that very briefly. To start, the pouch, that's the first part of the operation we do. Does size matter? And apparently yes, because when you have weight regain, that is related to the large pouch and the large outlet. And in this study, it was shown that patients with a larger outlet had less weight loss compared to the smaller outlets. Now, how do we do it? This is one surgery, so all the fragments you see is from one patient. We do a vertical pouch. It's calibrated on a 40 French gastric tube. We make a bit longer pouch as we do a bended bypass, which is at least 5 to 7, more 7 than 5, I must say. And then, of course, the horizontal stapling. And be careful not to make that too long, certainly not when you're using the 6 centimeter staple, because otherwise you may have an occluded fundus of the stomach, as you can see in that upper right panel. It's a different patient, by the way. Then we go retrogastric, find the crus, place a tunnel device, gold finger or pinky or whatever. That is to facilitate the position of the stapling that goes up to make the pouch, and you go nice parallel to the calibrating tube. And of course, it's important to stay away from the esophagus. Cut all the way, don't take any shortcuts, because when you cut a small part of the stomach after stapling, you will have a leak. Then next, I still split the omentum. Not everybody does that anymore, but I like to put the omentum at the end of the operation on the jejunostomy. And when you have very big patients, of course, it's wise to check before you start doing your bypass whether you have enough place to put your loop up. Then we do an estimated 60 centimeter biliary loop, anticolic, antigastric. We make a linear stapled gastric jejunostomy, side actually. Then close the defect with the V-lock. And interestingly, one of my PhD students recently has looked at that. The circular stapled bypass has a bit more complications, much more expensive. So I expect that the linear stapling will be in favor. Then we go to limb length, and that is a presentation in itself. You can discuss a lot about it, but I think that many items have been shown. First of all, the limb length. Brolin already in 92 showed that a distal bypass in the long term has no advantage in terms of weight loss. It is faster, but the end result is the same. Then we had this very nice study from the group of Berends and Janssen from Arnhem, where they looked at a long biliary limb. And initially they saw a good weight loss result, but however, looking up the 4 years result, they saw that the difference was disappearing. So limb length is probably not that much of an issue. What is important, that is what Abdelrahman Rumiro pointed out, you need to have a minimal total elementary limb length, which is the elementary and common channel together, of more than 250 centimeters. And one other very important notice from our, unfortunately, recently passed away, Nicolas Copinaro. He always stated, and I think he's perfectly right, do not combine malabsorption with restriction. So bypass means not too short. Now to go back a little bit on the length of the bypass, we have the Dutch obesity clinics, as was mentioned. I'm director of the south location of that, not of the entire, of course. We do about 4,000, 5,000, 6,000 procedures annually, a bit less now with the Corona time. Most of the groups do a long biliary limb, so the elegance type of bypass, and our group is the only one doing a standard bypass with, however, banded. And when you look at the results, I think that it is not really much different between the two. When you do a banded bypass, the results, as you can see, are a little bit better all over the way, but it means, in fact, that it does not really matter how long you make your limbs. Then we divide our biliary limb, and we do that that's a bit of modification of the Lonrod technique. We divide very close to the gastric jejunostomy to prevent the candy cane, the blind loop that was already mentioned. And then we do a measured, I do it measured, my colleagues do an estimated 1 m (20) elementary limb. I do it slightly stretched antimesenteric, and you have to be very careful with the grasper. Then the jejunostomy, it's side to side. I personally do it isoperistaltic, which is a bit more complicated than antiperistaltic, but I think it has an advantage. And on top of that, I do a modification of the Brolin stitch by using the V-lock to align the small bowel by doing some additional stitches, as you can see here on the right lower panel. Of course, like everybody, we then close the mesenteric defects, the jejunal defect and the Peterson. We use a hernia stapler for that, nowadays the EMHS stapler. And then, of course, we do a minimizer band, 7 centimeters for the female patients, 7.5 for the male patients, and after revisions. And then the complications. Well, nobody has complications, of course, but well, they can occur during a procedure. one you have to be very careful of course, is the staple in the small bowel. It can cause a perforation, certainly when you have a big patient. So watch for that. Grasper lesions are also an issue, but bleeding can be quite difficult, as in this particular patient. In the end, the procedure was converted to open because of uncontrollable bleeding behind the stomach. But it can also be from a solid organ, spleen or liver. It can be from the staple line, etc. And then staple problems, staple line failure. That can be due to the staple size, which is not large enough. It can be a mechanical failure, and very rarely a blockage of the stapler. So it will not open or close again, and then you have really a big problem to get it out again. It's very rare, but a difficult problem. And of course, you can have problems with tubes. And in this very particular case, the surgeon checked, the tube was moving freely, but he didn't appreciate that the tube had curled up and the tip went into the staple, causing, of course, some problems. And you have to be careful that you place the staple in the right lumen. So a little bit about immediate post-operative complication, only on the severe ones. These are data from the Dutch audit for the treatment of obesity, DATO. It's over the last 2 years. It's about 12,000 procedures. Most of them are the standard room-wide gastric bypass, about 2,001 anastomosis and nearly 800 banded bypasses. And you see that bleeding is about 1%, leakage 0.4%, and we had a little bit of high leakage in our own group, which is the main part of the banded bypasses. But of course, it's smaller compared to the rest. Overall mortality less than 0.04%, which is, I think, very well. And these data were collected by Herman Akpinger from one of my PhDs. Bleeding, I mentioned it. Leaks is also something that it can be an issue. When you have a bleeding, it can be intraluminal, you do an endoscopy. It can be abdominal, you have to do a real laparoscopy and treat it, or in very severe case, you can consider to do embolizations. Leaks, that is what we all fear. You see on the video a patient with an acute abdomen 2 days after the procedure. It's a bit older video because you see it's a elastic ring on the pouch. Checked for the pouch, no leak. So we went for the jejunal jejunostomy, no leak either. But this patient turned out to have a small perforation of the small bowel at the mesenteric site, and it was sutured and drained, and the patient did well. So that really was a grasper lesion. When you have an early leak, laparoscopy and drain, and you can place a stent. Late, you can consider to do a percutaneous drainage and stent the leak to treat it. Obstruction can be a problem. It can be kinking at the jejunostomy, which can even cause a blowout. That's why Fobi placed a ring on the stomach in his banded bypass procedures. It needs a relaparoscopy, and then you also need to drain the extruded stomach, of course. On the video, you see a very short part on a obstruction that was caused by one of these stents. The stent migrated and even caused a small perforation, so it had to be removed surgically. Fortunately, the patient did very well after that. There can be edema, and that can also cause an obstruction, but that's a matter of wait and see, and perhaps put in a feeding tube. And then the Roux-en-Y, which is a very rare complication, but of course it can only be solved by surgery. So it was very quick and very brief. Try to show you how we do the Roux-en-Y gastric bypass. I think worldwide it's more or less standardized, and as you can see, the limb length is not really that important. We all make narrow vertical pouches, which is important. That's the part that will not dilate. We do a gastric ring in our setting that works very well. Pouch outlet size can be important, but when you place a ring, it's less of that. And of course, we have to close the mesenteric defects. We do no drains and no testing. Well, thank you for your attention.
Thank you, Jan-Willem. That was a beautiful presentation as ever. On a personal note, you mentioned our study on limb length, and you say it doesn't really count or is not that important. I don't think our our study tried to prove if limb lengths are important or not, but it just tried to show a principle. And there are studies from the north, from Sweden, for example, that show that if you have an even longer BP limb length, that it just might have its influence on weight loss after all. But it's not the subject of your talk.
I can react to that because, of course, you're right. When you go very distal, you will have malabsorption. And we all know that you have very different length of your small bowel. So when you have a small bowel which is less than, let's say, 4 meters, and you do this very distal bypass,
I agree.
I
agree with you. Your call is leading in the. But as you know, most on average, a small bowel is 5.5 or 6 meters. So you have enough limb length in most cases to make a BP limb of at least 2 meters. And that's what Gislason and guys are doing. So, and I think there is an added extra 10% that you can reach there, but it has to be proven yet. I give you that. I'd like to ask you something about you mentioned stent placing after a leak. Is that something you do often? Because after all, it's a low pressure system, and in our experience, it often gives you more trouble than it helps you in curing a simple anastomotic leak. What's your opinion about it?
No, you're absolutely right. But well, fortunately, the number of leaks is not that high. But it can be, well, we just doing a laparoscopy, suturing of the defect is, I think, useless because it will never stay. So you drain. And then when you see that there's still a lot of production, we put in a stent in these patients. And stenting is a specialty. So when the stent is not placed very well, that's the case that you saw on the video, it can migrate and you expect it to pass all the way by itself, but apparently it doesn't. So that's why we had to remove that particular stent in this patient.
I see. I agree. And in sleeves, it's a total different matter. I think you always have to stand there, but it's in gastric bypass, I seldom do it. It's more in a very chronic leak that's not treated otherwise. But okay, my last question, I try to keep it short, is a bit of a philosophical question. It goes also to the earlier presentation of Dr. Kothari that says, taking into account all these late and, as you've shown us, early complications, and then knowing that the sleeve nowadays is the predominant operation in the world, why do you think it is that in the Nordic countries and in the Netherlands, the gastric bypass is still the preferred operation that we do? Why is it in your hands the preferred operation?
Well, first of all, I have never been a fan of the sleeve, as you certainly know. And in the Netherlands, initially, the sleeve was very popular as well. But we see so many patients coming back with weight regain. And then, of course, you can say it's an easy fix. You do a bypass or you do a SADI or you do whatever. But it is an issue. And also, I personally think that the reflux problem causing esophagitis, Barrett's esophagus, in young patients that have to live with that for a very long time is an issue. So it is a philosophical question. Yes, I think that you have to give the patient the first best option to treat, try and treat them the best way you can, and hopefully you can keep them that way. And of course, the multidisciplinary team involved pre-surgery, after the surgery, and on revision is extremely important. I think that is where the secret is in a good program. You have a good multidisciplinary team that will help your patient in all the way, this also on the long term.
I fully agree with you. Thank you very much.
Yeah. So hi, I think it's time to move on to the next presentation by Dr. Matthew Kroh. And it's my honor and privilege and pleasure to introduce my friend, Dr. Matthew Kroh now. He is the chairman of Digestive Institute, Cleveland Clinic, Abu Dhabi, and he studied from Boston University. He has got active research. There are many things that Dr. Mohit Bhandari has already told about him. He's a teacher par excellence. He has published more than 100 in the journals, in the peer-reviewed journals. He has more than 3 textbooks, and he's written chapters, 25 of them as I see it. He's an expert in bariatric endoscopy. He's been leading in that way. He's interested in GI surgery and has been interested in robotics. But what I really love about Matthew is, and which I'm going to say here in public, is that I love him because of the fact that he is an active marathon runner. He is as fast as a deer, and he has a lovely family. And the best part was when I was in Cleveland Clinic, I came there as a friend to Matthew Kroh. And because of that, I could open all doors without needing an identity card. Such is the love and respect for Dr. Matthew Kroh. So over to Matthew for his presentation, please. Matthew, you are on.
Yeah, it's coming.
Hello, good morning, good afternoon, and good evening. I'm Dr. Matthew Kroh. I'm the chair of the Digestive Disease Institute here at Cleveland Clinic, Abu Dhabi, and an associate professor of surgery at Cleveland Clinic Lerner College of Medicine of Cleveland Clinic, Ohio. And today I'll be speaking on long-term complications and interventions after gastric bypass. These are my conflicts of interest, none of which are pertinent to this talk. And this is my case mix disclosure, which shows a fairly equal distribution between primary Roux-en-Y gastric bypass, primary sleeve gastrectomy, and revisions and conversions with some other procedures as well. So bariatric surgery in the world continues to evolve, and this is one of the most dynamic areas of surgery. And Roux-en-Y gastric bypass has been around for many years, but in recent years, the rates and numbers worldwide have diminished. But we have many patients that have previously undergone this operation decades prior. And we've seen changes in practice paradigms, even at the Cleveland Clinic, with various operations that previously were performed no longer commonly being or not at all done so. And data after Roux-en-Y gastric bypass, which has been previously presented here today, shows good results with longer durations. These are some studies showing greater than 10 years results. And we also have high quality studies such as the Stampede trial looking at bariatric surgery versus intensive medical therapy for diabetes, 5-year outcomes, and we'll continue to get high quality data to drive our practices. But what about long-term complications and reinterventions? And I'm going to talk about Roux-en-Y gastric bypass for the rest of my talk. So there are early complications, which we're all familiar with, but I'd really like to focus on late complications such as hernia, internal hernia adhesive abdominal wall, and bowel obstruction is related to that, marginal ulceration, which is related to stricture and potentially gastrogastric fistula, biliary disease, commonly cholecystitis or symptomatic cholelithiasis, nutritional deficiencies, dumping syndrome, and of course, inadequate weight loss. So when we look at bowel obstruction, there are many areas based on the anatomy of the operation that this can affect. This can affect the outlet obstruction of the pouch. Internal hernia is probably the most common and most consequential. Adhesions from operative intervention, this is less common in laparoscopy than open. Mesocolic defects in retrocolic reconstructions, jejunojejunostomy obstructions, either from adhesions or mesenteric defects being opened. At the Peterson's defect in retrocolic patients or in the pseudo-Peterson's defect in anticolic patients, abdominal wall hernias, and sometimes combinations of all of these. Small bowel obstruction can occur, and the data is highly variable in terms of how frequently this occurs. This is a study that showed that there was about a 4.4% incidence. And in this series of more than 2,000 patients, more than half of the small bowel obstructions were due to internal hernia. So internal hernia may occur in up to 16% of patients. Again, a spectrum of data and follow-up. This is likely dependent on technical factors such as the variable locations, at the jejunojejunectomy, at the mesocolic defect and retrocolic root limbs, and then through Peterson's or pseudo-Peterson's defect. And then the variable closure techniques of suture, staples, and absorbable versus non-reabsorbable techniques. The length of follow-up increases likelihood of this occurring, and there's been a reported peak around 1 to 2 years after surgery. A recent randomized study showed that with closure of internal hernia defects, there is a significant reduction in overall incidence, but this may be possibly related to more severe complications at presentation. This is a study that also looked at internal hernia after gastric bypass, and with the spectrum of studies, 26 total and nearly 12,000 cases, the distribution probably reflects the time frame under which the study was done, these studies were done, and the reporting, but the overall mortality was not insignificant at greater than 1%. And often this is diagnosed with CT scan or other imaging. This shows a dilated remnant that's fluid-filled. The swirl sign shows swirling of the mesentery of the vascular patterns and potential obstructions upstream. And this will require surgical intervention, which might demonstrate something like this, which is ischemia at the time of laparoscopy. This is a patient of mine that had herniated the common channel through pseudo-Peterson space in an anticolic patient, and this defect was then closed with a running, locking, non-absorbable suture afterwards. So anastomotic ulceration, this is also unique to the operation, is likely multifactorial. And ulceration can occur in a broad spectrum of patients after Roux-en-Y gastric bypass, from less than 1% to up to 1/4, depending on definitions. This is likely dependent on technical complications at the time of the operation, the position and size of the pouch, and inclusion of potential parietal cells. This probably occurs more frequently in larger pouches, and then external behavior such as smoking. And chronicity may be in the order of days or months or even years after presentation. Early complications may be secondary to technical complications of the operation. Chronic processes, marginal ulceration, often are due to smoking or NSAID use. And this is a study looking at the cumulative incidence of anastomotic ulceration after Roux-en-Y gastric bypass in smoking versus non-smoking individuals. And you can see that over the course of time, up to 10 years in this study, there's a significant difference between smoking and non-smoking patients, which would not be unexpected. But the incidence is quite different as we go further away from the initial surgery. So on a progression of this, gastrogastric fistula can occur. This more commonly occurred in earlier eras of non-divided gastric bypass. It's relatively rare now, on the order of 0 to slightly more than 1%. The etiology is probably secondary to incomplete vision, marginal ulceration, or it could be iatrogenic. This may result in recalcitrant ulcer at the anastomosis from acid reflux retrograde, and sometimes with weight regain. Treatments had been purported with endoscopic methods, relatively low morbidity with this, but probably lower success, and definitive treatment typically is surgical with remnant resection. Nutrient deficiencies occur after Roux-en-Y gastric bypass, and I think it's helpful to think of them in terms of either macronutrient deficiencies like proteins, lipids, and carbohydrates, or micronutrient deficiencies like trace elements and vitamins, which are more common. This is a study with 3 years follow-up from Argentina, recently published in obesity surgery. It's important to remember that patients often have nutrient deficiencies beforehand. So in this cohort, anemia was present in 4%, iron deficiency in 5%, B12 deficiency in 12%, and vitamin D deficiency in 74% of patients. So at follow-up in this cohort of up to 3 years, deficiencies of calcium, magnesium, folate, vitamins A, B1, and B6 were seen at 1, 2, and 3 years. Anemia, iron, and B12 deficiency were higher at 2 and 3 years, not unsurprising after Roux-en-Y gastric bypass. And probably secondary to supplementation, actually vitamin D deficiency decreased over time, but was still the most common deficiency with 41% at 3 years. Dumping after Roux-en-Y gastric bypass, up to 1/3 of patients have postprandial hyperinsulinemic hypoglycemia. And these neuroglycopenic symptoms typically occur within 3 hours of carbohydrate ingestion. So because of the wide overall presentation and the definitions used by different authors, the exact prevalence is unknown. But in severe situations, this can decrease the quality of life and may also be a mechanism for weight regain in the future. Typically, this is treated with diet modification. There's some early data on endoscopic revision. Exceedingly rarely, this requires more severe interventions such as reversal for situations like profound hypoglycemia or significant symptoms. Biliary complications after gastric bypass are not infrequent. This is a study of a Swedish National Registry. They showed that the standard incidence ratio before Roux-en-Y gastric bypass at 3.42 was actually elevated based on a background population. They showed that a ratio peak of 11.4 occurred at 6 to 12 months after Roux-en-Y gastric bypass and recurred to baseline after 36 months. But in that cohort that had previous Roux-en-Y gastric bypass, there was a higher risk of conversion and acute cholecystitis with overall double risk of post-op complications. Because of the relatively brief time that I have to speak today, clearly weight regain can occur after Roux-en-Y gastric bypass, and along with this comes comorbidity development and recurrence. But I just want to mention that, but we're not going to delve into the data on that. What I do want to focus on, though, however, is reoperation after Roux-en-Y gastric bypass. In a spectrum of follow-up, the range is from 6 to 22% at 1 to 5 years. And the data varies based on follow-up periods and outcome definitions. Now, the most common intervention usually is biliary in the form of chronic cholecystitis or acute cholecystitis in up to 9% of patients. But there's also a high burden of endoscopy, and up to a quarter of patients who've had a Roux-en-Y gastric bypass may require an endoscopy at some point. So there's some data on this. This is a French national cohort study looking at long-term adverse events after sleeve gastrectomy and gastric bypass. This is a 7-year nationwide observational population-based cohort study with matched controls with Roux-en-Y gastric bypass and sleeve gastrectomy. Again, in this group, gallbladder surgery is most common. This forest plot with adjusted hazard ratios of 7-year predictive factors is for gastrointestinal surgery. And you can see the hazard ratios here of sleeve gastrectomy versus control and gastric bypass versus control, higher in that gastric bypass group. And in the same study, looking at an incidence rate per 1,000 person years with 95% confidence intervals, gastric bypass versus control, overall 26.3 versus 10.1, and you can see for a spectrum of other etiologies and indications. But if you look at the unadjusted p-value being statistically significant, this was true for overall surgery, gallstone disease, small bowel obstruction, and an anastomotic ulcer. This was not true for hernia after Roux-en-Y gastric bypass in this study. This is a study of risk of operative and non-operative interventions up to 4 years after gastric bypass and sleeve based on a US insurance claims database, 13,000 patients who underwent primary Roux-en-Y gastric bypass or sleeve gastrectomy. Primary outcome was abdominal intervention after surgery, and the patients were followed up to 4 years after surgery. On all accounts, except for revision, Roux-en-Y gastric bypass required more intervention. And these are graphs looking at time to reoperation, Roux-en-Y gastric bypass in that grayish blue and sleeve gastrectomy in orange. So for overall operations at almost 1,500 days after the operation, percent experiencing first event was higher in Roux-en-Y gastric bypass, overall operations. Other abdominal operations, unrelated, is also higher for Roux-en-Y gastric bypass at that same time interval. Endoscopy, higher for Roux-en-Y gastric bypass, but conversion or revision lower compared to sleeve gastrectomy, and the absolute overall numbers are lower in this cohort too, which is not unexpected. Now, I only spoke about Roux-en-Y gastric bypass. I think we have accruing data on other types of gastric bypass. This is our own small series from Cleveland Clinic Abu Dhabi looking at conversion of one anastomosis gastric bypass to Roux-en-Y for a spectrum of symptoms, including dysphagia, reflux, and malnutrition. More to be had on that is data accrues and larger centers report their outcomes. But as far as Roux-en-Y gastric bypass goes, in conclusion, short-term and long-term complications are different and important for surgeons to take into consideration. They're mechanical, physiologic, and other GI pathologies that are a major source of complications and reintervention, including both surgery and upper endoscopy. So it's critical that we pay careful attention to etiologies and presentation to mitigate the potential morbidity of these complications. And this occurs not just in the perioperative period, but years down the road as well. So thank you very much for your attention. It's a pleasure to participate in this meeting.
So thank you, Matthew, for this wonderful talk. I hope that you're ready for a few questions that I have jotted down from your presentation.
Indeed.
Yeah, Matthew. So we did touch upon the ulcers in marginal ulcers after Roux-en-Y gastric bypass. So I have got two parts of a question regarding them. One is, what is your protocol on chemoprophylaxis for these marginal ulcers, knowing that most of them occur in the first few months or the first year? And the second one is more challenging. There have been reports, and in fact, this year, in 2020, we had a huge literature published on ulcers which perforate or bleed from the gastric remnant. So I would like to know first from your experience on chemoprophylaxis, what is your protocol? And two, what is your experience on ulcers in the remnant of the stomach in Roux-en-Y gastric bypass, which can really be challenging?
Sure, great questions. And I want to thank you for the kind introduction, personal and interesting. So great to see you.
Thank you.
So our chemoprophylaxis is once daily proton pump inhibitor for 3 months. And we also use ursodiol during that same time frame for patients who have a gallbladder in situ. So 3 months of dual therapy for antacid and then for stone prevention. And then it's an interesting.
I know you're sleepy. Can you check and see what's wrong with my TV? You see my connection is
comment.
yeah.
Now maybe your mic is on.
Yeah.
And then
it's okay now.
As remnant pathology, so peptic ulcer disease of the remnant, I think is a spectrum of symptoms and has a huge national and international variation. So if I can parallel my experience from the States, where something like H. pylori is relatively infrequent, to UAE, where up to 30% of the population has H. pylori, and then maybe extrapolate to Asia, where there is a high incidence of gastric adenocarcinoma. All of these go into local factors as to what you'll do for these patients. And obviously an ulcer, a peptic ulcer typically in the stomach or in the duodenum after gastric bypass will present later because standard endoscopy is hard to do. And bleeding complications can be quite severe because of late diagnosis, either into the GEA typically, or hemorrhagic gastritis. So that can be very problematic. And I would say it needs to be tailored to the local population based on H. pylori prevalence and potentially even gastric adenocarcinoma. And I know that selection of bariatric procedures in certain regions of the world also take that into consideration.
Thank you, Matthew. So I have another couple of questions, if you don't mind. So pain abdomen after Roux-en-Y gastric bypass is not an uncommon entity. Patients do come in the follow-up and they complain of pain, some of which may be innocuous and some of which may be harbinger of dangerous complications, such as you mentioned, internal hernia. CT scan has not always been so productive and so pathognomonic. But what are the go-to tools, or what are those things that you want to hear from the patient, which tells you, am I dealing with an internal hernia? Should I do a diagnostic laparoscopy? So any pearls of wisdom out there, Matthew, from you, considering your vast experience?
Yeah, so first of all, you have to make sure it's not an acute emergency. Obviously, an acute presentation may require acute fast imaging and maybe an intervention like a diagnostic laparoscopy. And that's more straightforward. But typically we see patients who have this chronic intermittent pain, and they can be a little bit more of a diagnostic dilemma. You're right, the CT scan may or may not show an if patients aren't having obstructive symptoms. And there can be other etiologies too. So in a patient that doesn't have an emergent intervention for reintervention, I would consider an upper endoscopy to make sure that there isn't an anastomotic problem. I'd also look for other causes that could be seen on routine blood work, or maybe an ultrasound if the gallbladder is in situ. If after all of that, patients still have symptoms, then I think that probably the next step is a diagnostic laparoscopy. And the findings of diagnostic laparoscopy can be an internal hernia. I would look at the jejunocjejunostomy mesenteric closure. If it's a retrocolic roux, which is less common these days, and look for a mesocolic defect. Most commonly, this is a pseudo-Peterson's defect that either was not closed, because I think if there's a defect that's not closed in 2021, it's probably pseudo-Peterson's, or almost more problematically, it's a poorly closed Peterson's defect, where you can really get an incarceration or strangulation. I find that if patients have a wide open pseudo-Peterson's defect, they may have intermittent obstructive symptoms, but are at less risk for an acute strangulation. But they may have these kind of waxing and waning symptoms. But I think that diagnostic laparoscopy has very little morbidity, but can diagnose a problem in a patient that has chronic pain after gastric bypass and should be part of that treatment algorithm.
Thank you, Matthew. Just one last quick question to you, and that's more or less nutritional rather than surgical. So I know, but still important. And there's so much of literature now building up. Is it good time to consider intravenous iron over oral iron, considering the anemia rates? Is it time for surgeons to change their policy? Is it time to look into it again? Matthew?
It's always time to look into it. You know, all of our practices require constant reevaluation and different practice patterns. That's actually true of all of metabolic surgery, and I think it's true for iron infusion too. I think there's certain populations that are at risk. I think patients that have peri-operative anemia, dysmenorrhea, or hemorrhagic menorrhea are going to be at risk for this. Those patients may need additional supplementation. It's critical for us to continue to discuss, because as bariatric surgeons, we may be the only ones seeing these patients. Hopefully not, but sometimes yes. And it's up to us to diagnose this, and sometimes we overlook this. So it should be part of the armamentarium. I don't think it's routine, but there are at-risk populations.
Thank you very much. I think that wraps it up from my side. I'll hand it over to the chair, Professor Fobi, for the next session, please. And thank you, Matthew. Always a pleasure listening to you.
Likewise, thanks.
I think the next presenter is, go ahead, Vinod.
Yeah, thank you, Mal. It gives me great pleasure to introduce my friend and colleague, Professor Ramen Goel. Ramen needs no introduction. He's the Director of Bariatric and Metabolic Surgery at the Wokat Hospital in Mumbai. He's President of IGES. He's Program Director. He's Chairman of the Scientific Committee. He's Associate Editor of the Journal of Minimal Access Surgery and the Indian Journal of Surgery. He is the first center of excellence in metabolic and bariatric surgery in India. And on a personal note, he's well respected. He's affable. Him and his family come across to the United Kingdom very often. He's very closely connected with the Royal College of Surgeons of Edinburgh, and he spearheads the Indo-UK Surgicon, which is a great forum of collaboration between across nations. So Ramen, we're going to listen to you. Tell us, the last slot of the lectures is always reserved for the best. So when is a gastric bypass the operation of choice in bariatric and metabolic surgery? Over to you, Professor Goel.
Good evening, friends. I think it's a great pleasure to join Dr. Fobi and Dr. Mohit Bhandari, other speakers, and other faculty on this virtual Bariatric University of Mohawk Center from Indore. I think it's a very important platform to impart knowledge to young surgeons, and the topics are very carefully chosen, and the faculty are also the experts in this field. For today's talk, Dr. Mohit Bhandari has asked me to speak on when is gastric bypass the operation of choice in bariatric metabolic surgery. So when this topic was allotted to me, I was wondering, I said, when is it not a procedure of choice? And then I went through some literature, and I'm glad I went through it, because I learned a lot about the indications of gastric bypass, and I'm going to speak briefly about our own experience. So to begin with, I do not have any conflict of interest about this talk. This is my personal case mix. So till 2013, we were doing almost 90% of sleeve gastrectomy. And we started our bariatric surgery career in the year 2000. So it's almost 21-year-old experience of bariatric surgery. But by that time, 2013, we started seeing patients who were coming with reflux disease after surgery and after sleeve gastrectomy. So we started selecting more patients for bypass. And this is now, we are almost doing about 60% bypasses, 30 to 40% of sleeves. Now, what is a gastric bypass? Gastric bypass is a very broad term. Practically all the surgeries except the restrictive surgeries are gastric bypasses. So even a BPD is a gastric bypass in a way. And the principle is gastric size reduction and proximal enteric exclusion. If you look at it, actually Roux-en-Y gastric bypass is the only procedure which qualifies to be a gastric bypass, because there the pouch is so small and the rest of the stomach is excluded. Unlike one anastomosis gastric bypass or a SED or a DS, where you have a long gastric pouch and which has almost all the functions of the stomach in it. Now, we went through this American guidelines, the ASMBS guidelines, that how do you select a procedure? So individual of therapy, weight loss target, or the comorbidities, it also depends on the expertise of the surgeon who is doing it. Then the patient preferences and the risk stratification and others. So this is a very strong recommendation. And continuing the same guideline, if you see Roux-en-Y gastric bypass, the target weight loss is as good as with sleeve, slightly less than DS, and it's considered to have favorable aspect, which is strong metabolic effects, standardized technique, less than 5% major complication rate, and effective for GERD. And there are very few unfavorable aspects about it, especially the marginal ulcers and possibility of a internal hernia. Now, as I went through the literature, I found this publication by Kadier and group, where they discussed about criteria for procedure selection. And it says that the various criteria includes long-term weight loss efficacy, attitude towards food, and then morbidity and mortality. Now, the long-term weight loss efficacy and attitude toward food, the best is duodenal switch, followed by bypass, followed by sleeve gastrectomy, and then the band. And then morbidity and mortality is obviously higher in procedures with anastomosis. So it's higher in duodenal switch compared to Roux-en-Y gastric bypass, compared to sleeve and then band. And late complications varies between various procedures, and quality of life with number and severity of reintervention also varies. Now they have developed an algorithm which shows that if there's an obese patient who is a binge eater, then you offer them a duodenal switch. But the non-binge eaters, if they have GERD, then they should go for Roux-en-Y gastric bypass. If they have type 2 diabetes, and if the BMI is more than 50, then duodenal, less than 50, sorry, more than 50, it's duodenal switch. If it's less than 50 and person is not a sweet eater, then person gets a bypass. Suffice it to say that there are only two procedures that are being discussed here: duodenal switch and Roux-en-Y gastric bypass. Sleeve is only in patients who do not have reflux and whose BMI is less than 50, and they are the ones who wear sleeve. So if you are not doing duodenal switch, then probably wherever duodenal switch is mentioned, it automatically becomes Roux-en-Y gastric bypass. So there are very limited indications left for doing a sleeve gastrectomy and then we went through this study where a meta-analysis between Roux-en-Y gastric bypass and OAGB. Now this is a meta-analysis of a randomized control trial. So there are 3 randomized control trials of OAGB which have been included, and they have followed these patients for 2 years, all the 3 studies. And they said BMI decreased more with one anastomosis gastric bypass than Roux-en-Y gastric bypass. But the important thing is, in this, the one anastomosis gastric bypass, the standard limb length was 200 centimeters. The benefit of losing more weight was only in patients who had 300 to 350 centimeter BP limb. So they have other issues, nutritional issues, because now the standardized limb length have been reduced even to 150 centimeters. So practically we can say that weight loss benefit between these two in randomized control trial is not much. But patients with remission of diabetes was significantly more in one anastomosis gastric bypass than after Roux-en-Y gastric bypass. And there is no statistically significant difference in complication rates. So I think this is a very important meta-analysis, 1A evidence that except for comorbidities, there is, which is slightly better resolution, statistically significant resolution in OAGB. All other way, both the procedures are similar in terms of outcome. Let's quickly look at some specific situations. Let's say GERD. So this university study where they had distributed patients between sleeve and bypass. Sleeve patients, 20% had preoperative GERD, while bypass patients had 40% of them had GERD. But after 1 year, in sleeve patient, they found GERD in 74% patients, with de novo GERD in almost 68% patients. And they said sleeve gastrectomy procedure is a strong predictor of GERD postoperatively. While in Roux-en-Y gastric bypass, though the GERD was present in 40% patients preoperatively, it was only in 25% patients at 1 year after surgery, with de novo GERD seen in only 16.7% patients. So I think this is a very significant difference that has been seen. And then we went through a systemic review and meta-analysis of GERD, where 23 studies were included, 6 were RCTs, 6 were prospective, and 11 retrospective, with almost 5,000 patients. And they've said that risk of GERD in sleeve is significantly more than in Roux-en-Y gastric bypass. And improvement of GERD is significantly better in Roux-en-Y gastric bypass, sorry, it's not here, than with sleeve. So Roux-en-Y gastric bypass is more effective for treating GERD and has lower incidence of de novo GERD in bypass. So I think this is a very important indicator. The second specific condition is super obese, super obese. Now, this study from a university shows that percentage excess weight loss and BMI change, there is no significant difference seen in sleeve gastrectomy versus Roux-en-Y gastric bypass at 4 years. I think it's a very important thing to realize, because people automatically allocate Roux-en-Y gastric bypass in super obese, thinking that sleeve gastrectomy patients will not lose enough weight. But this study shows differently. Roux-en-Y gastric bypass shows slightly better resolution of comorbidities. Short-term adverse events were seen about 11% or 12% in Roux-en-Y gastric bypass versus 4% with sleeve. And post-operative complications were 26% in bypass versus 16% in sleeve. So this author came with this conclusion that sleeve is an effective primary procedure for super obese patients, even though Roux-en-Y gastric bypass achieves better midterm outcomes. Sleeve gastrectomy can be proposed as the primary option procedure for super obese. Now we look at the same criteria based on a systemic review and meta-analysis. There are 12 studies where they did the on super obese and super obese, and they found better weight loss at 12 months with Roux-en-Y gastric bypass, but no significant difference at 24 months. And statistically significant higher resolution of diabetes mellitus and dyslipidemia in Roux-en-Y bypass versus sleeve, but no significant difference in hypertension. So friends, weight loss wise, most of these studies have shown similar weight loss, whether it's super obese or super obese, but there's a difference in resolution of comorbidities. So this is how we can analyze our patients. Now, what are the relative contraindications for Roux-en-Y gastric bypass? Obviously, if there's a bowel disease, you will think twice. If there's a active duodenal ulcer, which may bleed in long run. Patients who are going to say, let's say a liver transplant, they may need a jejunum for a hepatic jejunostomy later, or patients who are going to be on medication like for psychiatric medications or immunosuppressants after a transplant, their dosage, the drug absorption may be impaired if we do a bypass of any kind. Now, one of the issues is a cirrhosis, and this is a randomized control trial published in 2017, where they had 66 patients randomized to sleeve gastrectomy and Roux-en-Y bypass, and they did intraoperative liver biopsy, LFT, and they found NASH in almost 55% of bypass and 52% of sleeve gastrectomy patients. And they found that after bypass, there is definitely significantly greater increase in INR in the whole group and also in NASH patients. And after Roux-en-Y gastric bypass, albumin decreased at 1 month But patients with NASH undergoing bypass are more susceptible to early transient deterioration of liver function than after sleeve gastrectomy, which is not maintained in long term. So in selected patient, one can think of doing bypass, but primarily sleeve gastrectomy is a preferred procedure of choice with most of us. So coming to our personal experience and the discussions that happen in various groups, recommendations versus practice. Is there a BMI-based recommendation for a specific procedure? Because a lot of people talk about doing a procedure, a bypass for a high BMI patients and sleeve for low BMI patient. Is there a comorbidity related preference for a procedure? And what about clinical practice? We published our outcomes a few years back, where we have shown that though the weight loss is higher in Roux-en-Y gastric bypass, which is, even at 3 years, but there is no statistical difference. So as far as weight loss is concerned, I can say that we can safely say that we don't need to offer it, make a difference between selection of Roux-en-Y gastric bypass, but it definitely gives a better weight loss, though it's statistically not significant. And then there are practical issues. If some surgeon is not experienced enough to do a bypass, it is better to offer a sleeve, or if bypass is indicated like a reflux patient, then refer to some surgeon who can do a bypass. In our own experience, a bypass may be technically challenging in more than 70 BMI patients. So I would rather offer a sleeve. And we have seen with these studies that even in super obese, the weight loss, the difference is not much if they are followed in long term. But in case there is a weight regain or patient does not lose enough weight, then bypass can be offered as a secondary procedure, second stage procedure, because ultimately safety of patient is more important. And then definitely the most important indicator is a GERD patient, and where bypass is preferred, and comorbidities is better resolution with bypass. Age extremes, teenagers and senior citizen, generally surgeons prefer a conservative approach. It's a usual dictum among the practicing surgeons. But we have realized that if we do not offer them the ideal procedure, whether it's a bypass or a DS or whatever, they do not lose enough weight, and then they get frustrated and they get psychologically depressed. So I think we should be very careful about offering procedures which is less than ideal in age extremes. And then patient preference. Generally, patients have a preference for a procedure because they know somebody in their family or neighborhood who had undergone a particular procedure. But that may be seen as a bias because that may not be the ideal procedure for the patient. So it's a good idea to talk to them in detail, saying why you think one particular procedure is better, and then let them take a call. So friends, to conclude, I believe Roux-en-Y gastric bypass still remains the gold standard for various reasons. Because it's a procedure of choice in GERD and comorbidities. It definitely has shorter learning curve than duodenal switch. Roux-en-Y gastric bypass has minimal malabsorption. I mean, various studies have shown that malabsorptive component is only between 5 to 10%. So the nutritional concerns which we normally see with the duodenal switch or with one anastomosis gastric bypass are much less, and very few contraindications, and have shown good long-term outcomes. So Roux-en-Y gastric bypass has stood the test of time, and I believe that there are many reasons for offering it uniformly to most of the patients. So thank you so much. I'll be very happy to take a question. And once again, thanks to the organizers for inviting me here. Thank you.
Vinod.
Yeah, thank you very much, Professor Goel, for that very enlightening lecture and for an exhaustive review of the literature. I'm just going to focus a couple of questions, really. You quite rightly mentioned about GERD and how that could tip the balance towards one of the three procedures. How do you define GERD in your practice? How do you make that call? Is it history? Is it endoscopy?
Yeah. So, Vinod, thank you. That's a wonderful question. Because I think GERD is the only determinant for the procedure selection in our practice. We do not differentiate based on the BMIs, on the comorbidities, but our primary differentiator is GERD. And we have tried everything from endoscopy to manometries and everything, but it's still patients, if we offer sleeve to them, few of them, they come back with reflux disease in future. So now, when they fill up a form, we ask them, do you have any SCP symptoms, heartburns, reflux? And obviously we do an endoscopy. If any of them is positive, even a history, we tell them that it is better to do a Roux-en-Y gastric bypass, because if they have developed a reflux 2 or 5 years down the line, and in India, most of the patients are paying from their own pocket, I don't want to offer them or expose them to a second surgery. So, we have a very low threshold for offering Roux-en-Y gastric bypass to anybody with even remote history of acidity or reflux.
And secondly, you very correctly mentioned about training issues and competence of surgeons. And you see across the world, the preference for a particular operation is very variable. Putting your training hat on, I mean, as a trainer, where do you think the future lies? You see the future bariatric surgeon as being skilled in sleeves and bypasses and more advanced procedures, or you see a more focused subtype specialist going forward?
I think there is no place for a person to be doing only one type of procedure. So it's just a matter of evolution of a surgeon, that he starts with simpler procedure, like how we started with VBGs, then we went to bends, and then to sleeves, Roux-en-Y bypass, one anastomosis bypass. So everyone has to learn most of these procedures over a period of time, and discard procedures which are not relevant. I mean, we did ileal transpositions at one time, and we gradually stopped them as we stopped the VBGs, bends, and now probably hopefully sleeve in next to 2 to 3 years time. So I think it's just a matter of time. Everybody has to be well trained to do a anastomotic procedure. I am not saying that everybody has to do a DS or a BPD or a SADI, but you must know to do a very well anastomosis laparoscopically.
Very final question. I know theaters are getting ready. In terms of gallstone disease, previously known gallstone disease, does that make an impact to your decision making?
Yeah. So, I just finished one patient with a sleeve and a cholecystectomy right now. So anybody who has gallstone, when they come to us for a bariatric surgery, irrespective of their symptomatic status, we offer them concurrent cholecystectomy. A majority of them do agree to get it done. But as we have a very large international tourist base, and they have these insurance in their own country, so some of them say they want to get it done later. But I think pre-existing gallstone cholecystectomy is the way to go. It doesn't change my approach towards the patient procedure selection. So procedure selection will remain the same, and only thing is we add cholecystectomy to it.
Thank you. I think Professor Fobi, are we kind of about time to get to theater? Or?
Yes, we'll skip the panel discussion at this time and go to the theater, and then we'll have a discussion at the end of the theater. So we'll be calling on the fellow or the consultant to present the patient that is going to be operated upon today, and then Dr. Bhandari would follow. Himanshu, give us the consultant with the patient specifics, please.
Hi, everyone. I'll be giving you the brief history of the case we are about to operate today. Patient is a 42-year-old female with a height of 167, weight of 120, and BMI of 43.15, non-vegetarian by diet, and known comorbidities of diabetes, hypertension, and obstructive sleep apnea. And with a HbA of 12.6 and albumin of 4.1 and HbA1c of 7.12, patient is scheduled for gastric bypass surgery. And she is COVID-19 RT-PCR negative. Over to Mohit. He's ready with
Dr. Bhandari.
Okay, good evening, everybody. We'll first do the intraoperative endoscopy. As all of us know that at our center, we don't do pre-operative endoscopy except for the revision cases, but do only intraoperative endoscopy. It is more feasible to do this because it is less time consuming, more comfortable for patient and also for the surgeon. And plus we have a very low dropout rate because of doing this intraoperative endoscopy. So in the esophagus, we would search for the lesions like GERD, hiatus hernia, esophagitis. As you can see here, once I have entered inside, this is the Z line which I can see. It looks pretty much normal. When I go inside the stomach, we would see for any polyp, any lesion, gastritis, ulcers, obviously hiatus hernia. This is the pre-pyloric area. We would look for any signs of any duodenitis or any other pathology like the duodenal ulcer. But most times this is required because we are excluding the remnant. And so therefore, all these lesions have to be ruled out. Once we are inside, we also see for the hiatus and look for the fundus, whether if there are lesions or anything else. So that's the whole logic behind doing this intraoperative endoscopy. Also, as I said, we are using carbon dioxide, and we do this endoscopy with minimal amount of time period so that there is no gas which enters inside the small bowel. The small bowel would be very easy to handle without any dilatation, as you can see, because most of the surgeons are not doing intraoperative endoscopy with the fear of spoiling the small bowel and having it too much dilated. Now I would take your attention to the port position. So at this point, you can see I have one optical port, which is just above the umbilicus. There are two 12 mm port, both in the anterior axillary line in line with the optical port, two 5 mm port, both below the left and the right subcostal angle, 2 finger breadths, both in the anterior axillary line. So as you can see, I'm working with total of 5 ports. One is the additional, I would not call it as port, but this is the needloscopic retractor for the liver, which is 2 mm, so very non-scarring. Nathanson's liver retractor usually causes pain, so we have given away with that, and now we are doing this with this retractor, and we are very much satisfied. The first look has to be at the hiatus, and then we would do the infracolic part first. Now you can see what the point which I was trying to make was that we have no dilatation of the small bowel. So you can see the small bowel here. There's absolutely no dilatation and can be easily managed. Now, as far as the gastric bypass is concerned, our steps are first dividing the omentum. So, just to seek out some time, I just divided the omentum before we started this surgery. I just want to save time after the patient is intubated. This is the inferior mesenteric vein here, and that's the ligament of Treitz. So we're going to just arrange this mesentery and arrange this loop of the bowel in a C loop fashion so that the bowel lies in front of us. So you can see I have markings on my grasper. I'm going to count 80 centimeters from the ligament and make an 80 centimeters of a BP limb. So this is 10, 20, 30, 40, 50, 60, 70, and 80. So that's the BP limb. Usually if we have a patient who is very severely diabetic and on a high dosage of insulin, we reverse this 80 to 120. So that's a little bit of change which we follow in making these limbs. But as far as this is concerned, 80 and 120 or 80 or 100 is the standard. Only in case of severely diabetics, we're going to change these limb lengths to 120 as a BP limb. So we believe that BP limb is more responsible for giving that metabolic effect to the operation. And that's why, if we have a diabetic, we're going to choose our limb lengths to 120. We score this mesentery a little bit just till the base so that, we do not have any tension on the loop which goes up to get anastomosed with the gastric pouch. Again, we count around 100, 30, 40, 50, 60, 70, 80.
All the faculty are invited
90,
to make any comments or questions
100.
during the
So
operation.
the significance of the elementary limb here is just to prevent the bile reflux. So anything between 100 to 120 would do. In fact, 80 would also do. Anything more than 50 is okay to prevent the bile reflux. So that's the common channel there. And this is the common channel. So this particular part is the limb which is going to go up and get anastomosed. And the other part here, this is the BP limb. So now we will anastomose this BP limb with the Okay, so this is the jejunojejnostomy. Now, this is standard 6 centimeters jejunojejnostomy, and most times what we see here is that this is sufficient enough. We don't do anastomosis using 2 staplers both the way, like a Y shape or a Y patterned anastomosis, which most surgeons do, to widen this area of enterotomy. We believe this is good enough. Just one stapling of 6 centimeters is good enough to sort of create a anastomosis which is patent. Again, this is closure by the staples. Surgeons can close it by the hand to end technique. They can, different other techniques, but we use a stapler to close it. And this is a anticolic anastomosis. So you can see this is the common channel. That's the elementary limb. You can follow it back up till here. This is the BP limb. So now we're gonna make a sort of a Brolin sort of anti-obstruction stitch, so that these loops, the BP limb and the common channel, they lie in the same this thing, and there is no kink. So if we don't take the stitch, you can see that this loop here can go and kink that way, and there can be a little bit of an obstruction later on. So we just take the stitch, and then this also serves as a stay for closing the internal hernia defect. So there's a large internal hernia. As you can see, this is the internal hernia, and we will absolutely close this defect. So the defect is closed by a non-absorbable suture. In this case here, it's a ethibond, which we're using to close these defects. So, and we use this ethibond also to close the Peterson space, the same defect. So we can also use silk here. I have used silk, I have used proline, different suture materials. But after we started doing the surgical procedures and standardize it to the endo stitch device, we have ethibond, which we use, and this is a Surgideck, as the company name suggests for this. Also, as you can see that most times it's difficult to expose these defects. But if you have the same lie like I have, the defect lies absolutely in front of the surgeon. There is no need for the surgeon to ask even the assistant to retract it. It lies right in front of us. So I just use this, a way of arranging the bowel loops, as I said previously, and that makes my job much more easier. And also, this is not an airtight closure. What we want is some nice adhesions here. And I have gone back to do lap choles in my patients, and usually we find that these stay there. We don't see internal hernias happening or defect enlarging with over a period of time. These are good adhesions which we can create by non-absorbable sutures. I haven't used barbed sutures here more. I don't have experience of using barbed sutures which are non-absorbable in nature and closing these defects, but we are very much satisfied by using the ethibond here because we have been using the same to close our hiatus. So this is a better suture than most other sutures in my own practice. So at this point, as you can see, we had a little bit of scoring of mesentery, which created a long line. Now this line is closed. And now I can see the BP limb, the elementary limb, and the common. So that's the common channel. This is the BP limb, and that's the elementary limb, which if you trace it back, can go up, and that's going to be anastomosed here to the gastric pouch. So that's for the infracolic part of the gastric bypass. And now I'm going to go to the supracolic part. Only one good thing which we did was that we sort of used a bougie to evacuate the stomach because I usually have some fluid there in the fundus which I cannot remove by endoscopy. So use a good 38 French bougie to evacuate this. This is the roux loop which is going to be anastomosed. You can see it is coming very easily up there. So I don't have a problem. Now at this point I would bring all this omentum down which I mobilized. We use a pars flexira technique to create the gastric pouch. So that's a standard at our center. I'm not going to go into the debate of pars flexira versus perigastric because when Dr. Fobi did most at our center were perigastric, but we never had difference in terms of evacuation or marginal ulcers, it's all the same. So 5,000 plus gastric bypasses, which I did, I never had problems with doing a pars flexida. It's easier to teach the fellows. Never had more marginal ulcers or complications as compared to perigastric, because some of the cases done by other consultants were perigastric at our center. But we are pretty much satisfied with this technique of pars flexida. So you can see that I have made a nice area there. I always try and remove this
Dr.
perigastric.
Bhandari, can I ask a question regarding this?
Yes,
Go ahead.
absolutely.
Are you not worried with the remnant stomach? You completely destroy the vagal nerve, and don't you see a obstruction at the pylorus due to that? That's what you fear when you do anti-reflux procedures. You try to preserve the vagal nerve, and here you completely destroy it. So, any experience on that?
Yeah, but what is the outcome? Even if suppose I destroy it completely or partially, what outcome does it have in terms of results in long term? I mean, I don't see different outcomes.
You don't see obstruction of the excluded stomach due to that.
We haven't seen that in our practice.
Okay.
Mohit, I think the only reason why this is not done by everybody is that in case there is a reversal of bypass required, then we may have an issue with if you do a pars flexida in every patient.
So we reversed couple of our bypasses. I've not had huge experience with that, but when I searched, so this question is, we had this question even before, and we reversed at least 15 to 20 of our Roux-en-Y gastric bypass, even the banded Roux-en-Y gastric bypass, 1 or 2 for excessive weight loss, the others were for non-healing ulcer. We never had a problem in evacuation of the remnant. Once we did a gastrogastrostomy, they did pretty well. I don't know, maybe the reason is that I did not, maybe in all those cases, the vagus was not completely severed, but we never had a problem in evacuation in those patients. So that's why we never stopped doing this. We have some data from Phil Shower and colleagues who have been doing this pars flexida since a long time at the Cleveland Clinic. And they also reversed their gastric bypasses and never had a problem in evacuation through the remnant. So we never changed this technique. In our initial 1,000 cases, we were a bit concerned about this issue, but then later on, once we had some data on reversal, we were not even concerned. And I personally, followed this patient up at that time. So no, I would disagree that there is, at least in our experience, we never had that problem of evacuation of the remnant after gastrogastrostomy.
Dr. Kroh, what do you do? I know you train at the Cleveland Clinic with Phil. Do you do the transection or the
No, I use the
perigastric?
pars flexida too. I agree with everything that Mohit said, that even in those, I think it's easier access. I think it's, in my opinion, less likely to have a thermal injury to the stomach because you're not using a heat source trying to dissect out that plane, which can be challenging, especially in big patients. And in those rare occasions where we've had to do reversals, I haven't noticed a big problem in terms of emptying of the stomach. Okay. Mohit, I have a question though. I also saw that you mobilized the phrenoesophageal fat pad, which I think is a great idea. It helps you really see that true angle of His. Do you do that routinely to make sure that you see the edge of the esophagus and the left crus on a gastric bypass?
Yeah, so I would do it. I would do it to the extent that I'm able to appreciate the hiatus. I would not very aggressively dissect it, but I would do it just so that I can see if there is a missing hiatus there. This is a 6.5 centimeters long pouch, a little longer than most surgeons would make, because we have been banding all our pouches. So maybe the standard of care at our center is to make this long a pouch. I know some surgeons would make a 2 centimeters pouch, maybe a little more shorter in length as compared to ours, but we have been doing this the same length both in our banded and non-banded gastric bypass as a standard.
Maybe a small question is a little bit of a sidestep from transecting the vagal nerve. I know that in chronic marginal ulcus, some surgeons tend to transect the vagal nerve in order to reach curation of that occurs. Is that something you would do? You probably would have to transect it a little bit higher.
Yeah, I thought even about that, but even if we transect it a little bit higher to preserve one of those nerves, in long term we haven't seen much complications happening here. In fact, none of them have been reported in our large series. So we kept on doing the same thing.
I'm sorry. Could it be that maybe your pars flaccida technique is a sort of a precaution for developing marginal ulcers then?
Maybe, but our marginal ulcers and gastric bypass are the same as reported in most other series, 2 to 5%. We have a very high marginal ulcer rate with mini gastric bypass, around 10 to 15%, I would say. And in gastric bypass, it's lesser. And maybe the reason why we have a lesser marginal ulcer rate in gastric bypass is because we transect that. But again, I cannot, substantiate that with more confirmation because of the fact that we have never studied the reasons behind why it is happening. Maybe the length of our pouch, maybe the way we do the anastomosis, the vascularity prevention during the anastomosis, all these are different factors affecting the rate of marginal ulcer. So there are so many predominating factors or determining factors here to prevent marginal ulcers that I actually cannot claim that our rate of marginal ulcers is less because of pars flaccida. I cannot say that with confirmation. This is a technique which we use to secure the caudal end of our anastomosis. It's a sort of a conal suture here. So what you can appreciate is that we have a very nice looking area here where we can go and we can see that there is no gap, which is completely secured. Now, what also this does as a technical standpoint is that if I leave this suture here and I go up and start to suture, this does not go anywhere. The simple reason being that there's no pressure on this loop here, which has come. So I can just hold it to triangulate my anastomosis. I actually stand on the right side of the patient. And because I use an endostitch device, it does not make triangulation necessary for me. But for surgeons who stand between the legs of the patient and use a conventional suturing method, this can serve as a very nice area where you can triangulate to any place you want to. So, the range of triangulation can go to any of the sides to make the suturing more comfortable. Whereas I do it this way, so I don't actually very honestly require any triangulation in so many cases we perform, but it can be useful for surgeons doing a lot of hand suturing. Plus, as you can see, not many surgeons practice that, but I utilize the anterior staple line to give some strength to my anastomosis. It's easier to take the staple line because it gives more protection to my anastomosis. It does not tear off the serosa while you're taking the staple line. It looks more secure to me. So this is something which I have not seen surgeons doing, taking the anterior staple line in their anastomosis and incorporating it. This area where I started my suturing, I again reach, so I can see this corner very clearly now. What I do is I cross this area of the caudal security which I took. And then once I have done this, I know for sure that I have completed this anastomosis without losing any, without having any scope of leaks in future. So that's
Mohit.
the gastrojejunostomy. I'm going to measure the gastrojejunostomy. I made an anastomosis of around 2.5 centimeters, but when we do an endoscopy, it becomes around 2 centimeters, and that I'm going to check. Now we have the last.
Somebody had a comment.
Yes.
A question.
Yeah.
Mohit, it's Vinod. It's a lovely demonstration, and you answered my question. I must have missed the size of the stapler cartridge you used. Was it?
So we use all 6 centimeters cartridge here.
Okay,
and
yeah.
The length of our anastomosis, which I make, is usually 2.5 to 3.
Right.
But because I do a little bit of burying of this mucosa and serosa, I make it to 2.5 or 2 centimeters at most. So that's what I do. And when we do an endoscope, we can check by because the lumen of the endoscope is 1.5 centimeters, 1.3 to 1.5, the Olympus scope which we use. And so we can actually make it out that the length is reduced to 2 centimeters because it's absolutely snug.
Yes.
This is the Peterson space. So as you can see, the biggest challenge here is in demonstrating the space. So what I usually do, I ask my assistant to rotate all this omentum up and then hold this area here. Now you can see, we can clearly see this space. And once we are able to appreciate the borders of the two space we need to close, the closure becomes much easier. So I feel that if we expose the Peterson space properly, it's more easy to close it. So we start from the base and then we go up towards the colon. So again, the intention here is not to do a very airtight closure, but just to come around and make some additions here, which are more helpful for the patient in the long run, so that there are almost zero chances of developing an Peterson space hernia. So this is the area which is most prone. So I'm gonna stop my suturing here. Although there is a space here, but that space is not amenable to the small bowel because we already closed very nicely at the base. Most hernias which I have seen, they happen at this area. So this is the area here, as you can see. So that's the area where most hernias would happen. So that's the area which I closed completely, and that aborts the chances. So this is my jejunojejnostomy. As you can see here, we have here, this is the common channel, that's the BP limb, that's the elementary limb. This is my internal hernia which I closed. I can trace back the roux limb here. So once we trace this limb, you can see that the limb is coming here and it goes towards the gastric pouch, which is 6 centimeters in length. I will do an endoscopy and check how this anastomosis looks like from inside. This endoscopy is not purposefully done for any sort of checking for leaks or something. We don't check for leaks, but we just do an endoscopy to check for bleeds and general patency, because sometimes I realized that even though we did a single layer anastomosis and we were sure that the anastomosis is patent, we can make this very, very small, and that can cause a lot of nausea, vomiting, and regurgitation immediate post-operatively. So I just put in a scope to just make sure that my anastomosis is patent and I have no bleeding inside. The same can be very well done by putting a bougie inside, but I think bougie can be forced inside to the extent that you may not realize that the anastomosis was a little tight. This is the esophagus. I expect a little bit of blood here. That's the GE junction, that's the Z line. And so you can see that's the Z line. That's the pouch. The pouch is exactly 5.5 centimeters to my, what you would say, length of my scope. Now you can see I'm inside the bowel. So that's what I was trying to make. So that's the, small bowel which we have. It's a very small, I would not say candy cane, but very small remnant here. And now when I take my scope back, you can see this anastomosis very clearly. So this is a nice anastomosis. I would not say it's more than 2 centimeters. If you can appreciate here, I pull my scope back and now I can, put a little bit of air to demonstrate that that's the staple line here. Now you can see the pouch from inside. So it's not a very, very large pouch, and that's the Z line. So thank you very much for your kind attention. And I'm ready.
If I may, are you going to place a band?
No, this is a conventional gastric bypass which we did today. This patient has given a negative consent for placing a band. We counseled him for that. We have a couple of patients who, despite our counseling and giving them the opinion that that's our data, do not consent for a band. So
okay, and then a very philosophical question for you.
Yeah.
We all know the metabolic effect of the bypass by bypassing the bowel, but when a patient regains weight in time and the bypass is still there, they will get all their comorbidities back. So what are we aiming for? Is it sustained weight loss, or is it a metabolic effect of the bypass?
So this
long term, apparently the bypass effect is wearing out, and it is the weight that is important.
So I would say that this particular patient, I think if we have a banded bypass, it's a strong restrictive option with very minimal metabolic effect. So here, to answer your question, we are just aiming at restriction. I don't see a lot of metabolic effect with this procedure. We see metabolic effect with gastric bypass only when we go 120 centimeters as a BP limb. as I already mentioned, for diabetic patients. So this will be more of a restrictive procedure until the time it works.
I cannot agree more. But the long-term effect on all our comorbidities is mainly weight related. Maybe not for the lipids. That is the different issue, but certainly for diabetes.
To me, I don't think a pure gastric bypass is a very good operation. I think we should ban all our bypasses. They then gives you the maximum strength of restriction, and bypass are as good as a very highly, very strong restrictive operation with very minimal metabolic effect. If we really want to see metabolic effect, limb lengths have to be, somewhere around 150 centimeters a BP limb. 150 to 180 gives good metabolic effect.
Is Dr. Kothari still on board? I don't see him. Is he? Shanu? Okay, Dr. Kroh?
Yes.
Yeah, I was going to ask, we in the States, we train and make the gastroenterostomy very narrow. We make it over as nasogastric tube. What do you think about leaving a 2-centimeter gastroenterostomy?
I think it's probably okay. It was presented earlier about weight regain and pouch size. I think that ideally it's got to be about at least 10 millimeters to not cause dysphagia. Probably 15 is ideal, and probably more than 20 is too big. It's never an ideal amount. Sometimes you see patients who've had weight regain, you see a big anastomosis, but you can't assume that it's secondary to that. You also see patients that have done fine, and they may have a 25 millimeter anastomosis. So I do think that there's some degree of restriction or satiety with the small anastomosis, and in the States, we tend to make them quite small. There's an upper limit, I would say probably 20 millimeters, but probably not a big difference between 10 and 20.
Yeah, I'll make a comment that having worked both in the States and with Mohit in India, I think most of our readmissions and peri-operative complications in the United States are due to the fact that we make very tight gastroenterostomy, and it's been difficult to get doctors to get away from it. We looked at the rate of weight loss between what Mohit did, and when I got there, I was doing the narrow gastroenterostomy, and there was not much difference. So I've tended to go with him towards a larger gastroenterostomy of about 2 centimeters. However, since we do mostly banded procedures, the stoma doesn't really matter. That large stoma prevents the incidence of stenosis in the postoperative period. Any other comments, my colleagues? Vinod?
Yeah. Mohit, firstly, a fantastic demonstration, and it's very slick and it's an excellent watch. And the thing that impressed me was how you closed the mesenteric defect in the infracolic compartment. Everything was like an open book, and you could see the edges. So personally, I've picked up a trick from that. Regards the top end, the supracolic, the gas, have you changed your practice to endoscopy post anastomosis, or have you used kind of methylene blue kind of traditional thing to check for anastomotic integrity previously? And if so, what made you change other than availability of the scope?
No, I never did. I've done some 5,000 gastric bypass and around 6,000 mini gastric bypasses. So I have never done a methylene blue test in my life. I have never done a leak test in my life. Dr. Fobi was there. He still observes me, is still, with us, and he knows for 4 years he was here physically. He has seen I have not done a single leak test. Must have seen around 5,000 procedures. We've never done, we never do them. So I have no experience. I don't know.
Yeah. Well, what do the rest of the panel do? Interesting.
Jan, do you do a leak test? What about you, Matthew?
I do a leak test, I actually like Mohit's comments. I do an endoscopy at the end, and I do it to test integrity, but I also look for bleeding, and I look at pouch morphology. Yes. And in particular, I liked, Mohit, your use of the used stapler to occlude the roux limb. I thought that was pretty slick. I may use that myself, but I think endoscopy is very valuable. I think that bariatric surgeons need to be facile with an endoscope, and I think an endoscopy before, either immediately before or pre-op and after, gives you a lot of information about the anastomosis. To be honest with you, when I put a scope across my gastric bypass or a mini bypass and I see both the loops well open, it gives me a very comfortable sleep. So I absolutely agree that would require the hospital privileges to come with the surgeon like you have, Matt, and like I have. But I think in centers who do not have this facility,
if they are doing methylene blue test to check the patency and leak, it's good. But I have no experience because I never required the need to do that.
Mohit,
Okay.
I have a question for you.
Go ahead, Baig.
Yeah.
ahead.
So Mohit, I've seen your video operation so many times. It looks like you do it just the same thing all over again. It's like seeing the same video again and again. You are absolutely perfect every time. But here's a question for you. Preoperative endoscopy, you would like to do it intraoperative. Would it ever make a difference to you that intraoperatively you thought, okay, I should have done this, maybe 2 days back? It would have changed my decision on the operation. Is there any situation during your surgery that you found that intraoperative endoscopy was a mistake? You could have done this 2 days back. Maybe it would have changed your plan.
So this is an interesting question. We change our plan very frequently. We have a blanket consent. I don't let the patient choose the procedure for me. I choose it for the patient. And if he does not give the consent for anything and everything which is going to happen inside the theater, starting from abandoning the procedure or changing a sleeve to a Ruawai or changing a Ruawai to a sleeve or changing a sleeve to a MGB, he does not come to my table. So, and we presented this data on intraoperative endoscopy. We change our procedure in 12% of the cases. So
2.4%.
Sorry, 2.4. Pardon me, 2.4% of the cases. So that happens at our center. So that's okay.
So for the 2.4%, you don't want to go and do your endoscopy prior to the surgery? You still think this is okay?
No, I see at the end of the day, I have seen, now let me be honest with you. I have seen gastroenterologists who did an endoscopy, did not report a hiatus. And I had a large hiatus inside. I have seen endoscopies not reporting to me a duodenal ulcer, which I had. So to be honest with you, I feel that this approach which we do is more comfortable for the patient. We have very less rate of patients missing on bariatric surgery. They are very comfortable. We can do the endoscopy at a lot of ease rather than patient, bugging and, having refluxes in the OPD. It's a very terrible experience for most of the patients. So I'm very comfortable with this approach. Plus, I also realized that it's not only the endoscopy which could change my decision. I have ultrasounds which come grade 3 fatty liver, and we enter inside and we find cirrhosis. I go inside and I found bowel lesions which preclude doing a gastric bypass. So, I think every surgeon should do two things. First, he should learn all the three procedures, sleeve bypass and mini bypass, or at least two of them. And second, he should take a blanket consent. We shouldn't be dominated by what patients say or what patient wants. I think inside the abdomen, when you put in a scope, the story can be totally different.
Okay.
Shanu, you were away. Do you want to make any closing comments?
Oh, I've enjoyed this conversation regarding provocative testing. It is a provocative topic. There's endoscopic, which is what I do, bubble test. There's the methylene blue, and now there's some emerging literature actually using ICG as the provocative test. There's only, to my knowledge, only one prospective randomized trial where they showed that it helped, but that particular study had such a high leak rate, like 8%. I don't know how much we can really draw from that, but from all of the MVSA quip analyses and things like that, we haven't been able to see a documented change in complication rate, whether it be leak or bleed. But at the end of the day, I think if it allows you to sleep at night and feel better about your operation, I'm not opposed to it, and I do it in full disclosure.
Okay, Dr. Berends, Frits, any comment, closing comments? Are you still there?
Not really, no. I was curious about the final gastroscopy. How often, Mohit, do you encounter there an internal bleeding? And if you do, are you equipped to treat that right away?
Yeah, we encountered very severe bleeding 2 or 3 times. So I had some material. Only twice I used one material that can be delivered through endoscopy. It's like a glue. It's like an endoscopic glue. We used it once in 2000, long back. sometimes we find minor ooze. At that time, because we have a laparoscopic endoscopic combined guidance, I find out the area from where it is oozing. If it's an anastomotic site, which mostly it is, I take a suture or two. Sometimes I have bleeding from the staple line. So I go and clip outside and maybe take a suture or two. So I am concerned, and that has happened, as I mentioned, only 2 times with me where I had torrential bleeding. Once I used a material, the endoscopic glue we have in our operating room. It has a very small shelf life, so it's very it's not financially viable to. Baxter produces one comes from J&J. Both are for endoscopic use. Boston Scientific also produces one. Very, very small shelf life. So we try to maintain one just for once in a blue moon scenario. It has an endoscopic applicator and you can put it directly spray mode. I did it long back, years back, if I remember. Apart from that, as you said, localized bleeders, it's very good. If you see it in the endoscope, you can go in, you can locate the area exactly, and you can manage it by laparoscopic guidance. That's the beauty, because we have both laparoscopic and endoscopic guidance here.
Okay, Ramen, let me ask you for the final comment. Any particular questions of Mohit or about the session?
So I think Mohit has done a wonderful surgery, sir, as usual. About the endoscopy part, what Sarfaraz was asking, I also have that reservation. So we do endoscopies routinely, either pre-operatively or on the table. And there have been instances where we found some large polyps inside, a suspicious polyps, and we had to abandon the procedure. So in COVID times, we are doing all of them on table nowadays with the surgery because of this COVID requirement. But I believe if it is possible for the program to offer it in advance, it's always better, because a patient who is coming on the operation table and then is being told that surgery cannot be done because you have a active ulcer inside or you have a large polyp, we have to take biopsies and wait for the histopath reports. So I think that is more of a concern. And as Mohit himself is saying, large bleeding on table are hardly seen. 2 patients out of 10 or 12,000 bypasses that he has done. I do not think post-operative endoscopy has that kind of return as what we put in, the effort, because person doing the endoscopy has to be very good. Anesthetist can't do it. Surgeon has to be very good with the training to put in a scope in a supine position and identify the bleeding site. So I think these are individual variation, but excellent demonstration, and really enjoyed it.
Yeah, just for correction's sake, Mohit does not do routine postoperative endoscopy. This is just done for this as a teaching session. He does routine intraoperative, preoperative endoscopy, but very rarely does the postoperative endoscopy, except he has questions about bleeding. But since this is a teaching webinar, we encourage that he do it. And so I'll summarize by saying the gastric bypass is still an excellent bariatric operation based on what all of you have presented here from all the experts. The incidence of internal hernias is significant, as Dr. Kroh says, and Shanu mentions, goes up to 16%. And I think it will be very inappropriate for any surgeon not to close mesenteric defect, because that does occur. And then finally, as Mohit has shown, people who say the sleeve is an easy procedure should know that they can do a gastric bypass procedure in 22 minutes, just like Mohit did, if you have a team approach and you learn how to do the procedure. And with that, I'll thank you all very much. We invite you all for the next webinar in a week, where we'll be presenting one anastomosis gastric bypass. And at this time, I'll ask Mr. Himanshu to give us the promotion. Mohit, make a comment while the promotion is coming on. Thank you.
No, thank you very much, everybody. And we hope to see you next week. And great discussion, great points made. I learned a lot. Thank you so much.
Thank you, Mohit.
Good.
Thank you very much.
Thank you.
Be safe.
Thank you.
Namaste. website for your review at your convenience. See you all next week. Thank you. Thank you.